All right, so we will go ahead and get started here. I think probably most everyone who's going to join is here. So first, I would like to welcome everyone to this second focus group session for the Oregon Prescription Drug Affordability Board for the non-grocery group, which was expanded to include not only pharmacies, but PSAOs and GPOs. My name is Linda Wyant, and I am a healthcare senior manager at Myers and Stauffer, and we are a national accounting and compliance firm supporting government-sponsored healthcare programs. And I am also joined by my colleague, Bobby Courtney, who's a principal here at Myers and Stauffer, and he will be helping to facilitate today's session. So we'll start with some logistics. As a reminder, we are recording these sessions to capture the feedback correctly. If you wish to speak and are uncomfortable with having a specific comment recorded, please let us know and we can temporarily stop the recording. So also joining us from the PDAB board, we have board chair Shirley Bailey. And from the PDAB staff, we have executive director Ralph Magrish and Courtney Whitlock. And then finally, I would like to introduce Jane Horvath of Horvath Health Policy, who is also supporting the board with their work. So as we begin today's sessions, first, again, I'd like to thank you all for attending. Your time is incredibly valuable, and we appreciate your willingness to share your perspectives on this important topic. And so we welcome especially any of our new group participants that are joining us for this meeting. So for this meeting, I will do a quick refresher of a few of the slides that we presented at the first meeting. And then following the slides, we will continue the constituent group discussions from meeting one. And as a reminder, our goal with these sessions is to get your perspectives on the use of upper payment limits or UPLs to improve drug affordability and gather any recommendations you have on improving drug affordability for Oregonians. These sessions will inform the board's work on developing a plan for establishing UPLs as required under Senate Bill 192. At this time, the board is not setting a UPL, but rather is gathering information to include in a report to the legislature regarding potential approaches to a UPL. So we will capture any questions or concerns from the group as we are preparing our reports for the board. And when we do get to that point in the session, we would ask that you introduce yourselves if you wish to speak so that we can accurately capture your feedback in our notes. And we do ask that you please mute yourself when you're not speaking. And while we can't answer specific questions related to methodology or affordability evaluations, we do have a mechanism for you to submit those directly to the PDAB for consideration. And that's on both slides, and I will put it into the chat in just a few minutes. All right, Allison, if we could go to the next slide, please. So again, for the purposes of level setting, since this presentation is being given to multiple constituent groups that have different roles in healthcare and different understandings of the supply chain, this slide is intended to illustrate a basic process for retail and health system or physician-administered drugs and their associated systems of payments, rebates, and product flow. We recognize that it's a highly simplified diagram, but it's an attempt to get all of the constituents to somewhat a similar level of understanding. In this diagram, we're describing a situation in which the UPL is implemented at the top of the supply chain flow. So, Allison, if you could go to the next slide, please. We also offer a little bit different way of looking at this. So we offer this as a conceptual representation of the potential UPL model, and this is adapted from work conducted by Jane Horvath. Specifically, it's intended to illustrate the progression of the UPL through various parts of the pharmaceutical supply chain. And as a reminder, the concept sits between the manufacturer and the wholesaler. And so currently the supply chain is oriented primarily around a wholesale acquisition cost or WAC, AWP, MAC, FUL, federal upper limit, or other similar metric. In their 2022 report to the Oregon legislature, the board describes their concept for a UPL in Oregon, including that it establishes a maximum amount that can be paid for a prescription drug, in a concept that is likened to federal upper limits, NADAC, or MAC prices that are currently established and used in prescription drug reimbursement today. And so the proposed model would be for the UPL to replace these metrics for all supply chain transactions along this continuum for a prescription drug product being dispensed or administered in a state when a UPL exists for a particular drug. And as noted in the diagram, the UPL is intended to be independent of dispensing or administration fees. Allison, next slide, please. So as a reminder, we looked at recent industry events that might serve as a guide to how a UPL might work in the marketplace. And we will come back to this session or to this concept in this session today. But most notably, as I would imagine everyone on this conversation is very familiar, there was a recent change to the federal Medicaid drug rebate program rules, and those had an impact on rebate rates that would be paid by manufacturers, in some cases significantly. And in response, manufacturers for certain highly rebated drugs in the Medicaid space implemented reductions in WAC for these drugs. Next slide, please. All right, so now we will move into the actual discussion part of this conversation. And as a reminder, we do wish that you would remain on mute unless you are commenting. And if you would, state your name and organization for us when you are making comments. Zoom does have a feature to raise your hand. It will help us make sure everyone has an opportunity to speak. So if you will use that feature, we will recognize people to speak so that we make sure we don't miss anyone. As I mentioned, there are other opportunities to provide feedback. Written feedback can be provided as indicated, either in response to the survey. Of course, I've got 531 here. Sorry, that's a copy and paste error. We do intend to leave the survey open for the PSAOs, GPOs, and certainly if any pharmacies wish to participate, you can certainly go ahead and submit that survey response. You can also provide information directly to Myers and Stauffer at the Oregon PDAB email that is listed on the slide, or you can participate in the public comment process and by writing and submitting a letter to the board or signing up to speak during a board meeting, and the participation form can be found on their website. All right, so Bobby, I will turn it over to you now to start the focus group discussion.
Sure. Before I jump in, it looks like we may have a quick question there from Melanie. Melanie?
Yes, good afternoon. Melanie Maxwell with Align RX, PSAO that represents just under 4,000 pharmacies nationwide, and we have a significant number of pharmacies in the Oregon state that we are agent and representative for. Just a couple of quick items to get to here. First, I did look at the survey that you guys sent. There are multiple surveys depending upon the type of organization. However, it really is not clear which survey category you want PSAOs reporting through or responding through. So if we could get some clarification on that for PSAOs, which survey do you want us to use? And then the second,
you started to cut out there a little bit at the end, Melanie. Can you just the last thing you said? That I heard the direction in terms of which kind of survey path to follow, and I thought there was maybe something you said right at the end there as well.
I was just getting ready to transition into the discussion that I'd like to put out there related to the use of a UPL in a PDAB type environment. So am I good to proceed with talking about the UPL?
Sure.
Okay, great. So there are a couple of things. I thought it was very interesting that one or two slides back, you were comparing a UPL to the hopefully to get the same impact that we saw with WAC prices being lowered. And I think that one slide actually is a huge thing to consider, whether or not you can expect the similar result with a UPL. And I think it's going to show some of the problems that a UPL based methodology, you're going to miss the mark there. The reason that the Medicaid program and that rebate program was successful in lowering WAC was because those rebate laws or policies directly impacted the manufacturer, who is the ultimate price setter. And so that's why that rebate program was successful in getting WAC prices lowered. A UPL, a UPL is not directed specifically at the manufacturer. What you're trying to do with a UPL is come through the health plan and the provider to then create downward pressure to get back to the manufacturer to lower price. And so you really, UPL is going to be dangerous because for price lowering to occur, the first thing a UPL is going to do is put pressure on the reimbursement side. You're going to set the reimbursement maximum, which means the provider, whether it's us or as retail pharmacies or the physician, we then are going to have to make a decision on whether or not we can afford to provide that drug product to patients. So the first thing a UPL is going to do is create a huge patient access issue to care. And so I don't think anybody that is part of this group or other groups nationwide looking at similar approaches, I really don't think that's their intent. They want to try to figure out how to impact pricing and affordability without creating a patient access problem. And so for that, to me, that's the biggest reason I think I would encourage you guys to really think hard and long before you go down this pathway. I think there are better, other more effective ways to get to affordability that does not put the provider in the middle and having to become then the bad guy on restricting access to drug product. I mean, retail pharmacy is still a retail type business, and retail businesses survive on margin. And implementing or fixing a price on reimbursement for a product is just simply not a smart move. There is also not support, from what I can see, there is not support nationwide from the health plan sector. And in fact, you've got some executives of different health plans that have actually come out and said that UPLs are not going to ensure affordability because there's no requirement or connection that those savings be actually passed on to the individual person themselves. So again, I think starting with a UPL to try to impact affordability is right idea, but wrong approach, wrong method. I wouldn't say that you're going to see success starting with a UPL. So that's really just kind of the information that I wanted to throw up there for consideration. I'm happy to, if anybody's got a question, if that's allowed, I'm happy to dive deeper if I wasn't clear on any of those points. But I appreciate the opportunity to lay it out there.
Yeah, no, thank you for those comments, Melanie. Couple quick things. In terms of the survey, Allison, do you have direction in terms of which survey path Melanie and her colleagues should follow based on the way that you structured it?
Yeah, no problem. I put it in the chat as well. Once you actually enter the survey itself, you'll have a drop down that gives you the option of PSAO, and it'll guide you through the questions that are then specific to PSAOs. If you want to preview those questions, which I know there's like a set of links where you can preview the questions before going into the survey, the wholesaler list of questions is actually the same that we use for PSAOs. So thank you for that feedback, and we can look at getting that updated on our survey instrument.
Appreciate
Does that help on point one, Melanie?
It does. When I have a full disclosure, I actually did click the link and didn't see the PSAO option out there when I did it last week. So I'll look again just to make sure it wasn't user error. So
great. And don't hesitate to reach out to the Oregon PDAB at mslc.com email if you have any challenges moving forward. On your second point, I really appreciate the feedback and the comments there. I'll kick it to Linda in just a second to respond to kind of the intention of the slide that was presented. But just want to say, in terms of in terms of being able to kind of respond, to specific comments, these sessions are really designed as listening sessions. We want to solicit the kind of input that you just provided from all stakeholders, really to support the board's statutory obligation to provide some recommendations on a UPL to the state legislature. So, really this is driven by state law. It's the board's intent here is to solicit exactly the kind of feedback that you and other stakeholders in the supply chain have around the concept, and hopefully, we've got some structured questions that we'd like to go through today. Hopefully, that'll provide some opportunity to help the board think through some of these issues. We've heard comments from others about the access concern as something that you had mentioned, and really think about what we'd really like to hear from folks is what are some of those things that the board might recommend to mitigate that, or are there other solutions that the board should be considering or focusing their efforts on. So certainly more to come in the conversation over the course of the next 40 minutes that we'd love your input on. But with that, Linda, I wanted to give you an opportunity to kind of point out that this is more of a conceptual analog really to the idea of a UPL.
Right. So I asked Allison to pull that particular slide back up. And so, Melanie, it was intended to be something that might serve as an analogy for how UPL might similarly impact the supply chain, for better, for worse, and perhaps for neutral. And for the purposes of this was not really to talk about, of course, rebates or the Medicaid program or anything like that, but just to offer this as a potential model, a potential concept, a potential analogy for how a UPL might similarly impact the supply chain or not. So that was, merely the intent on this. All right, Allison, I think we can go back to the last slide and start to work through the bullets of the actual discussion points. And I will turn it back over to you, Bobby.
Great, thanks, Linda. So just before we start off, I just want to thank folks for their participation today, particularly those of you who were able to attend the first session as well. If you were able to attend the first session, just a heads up, because we do have some new attendees. We'll probably try and touch on some of the things that we did discuss last time, just to make sure that we're giving an opportunity for everyone to provide input and feedback. And then, again, towards the end, really similar to what I just had said to Melanie, really look for this group to provide, any and all recommendations that you might have that you would suggest that the board consider in their efforts and sort of in meeting their obligation under the legislature. Couple quick things just to reiterate, do this every session. Just want to make sure that the board does intend to leverage this information in their report to the legislature. And as a reminder, we are recording. So if there are comments that you'd like to make that you don't want recorded, please just let us know beforehand. We'll push pause. That's a non-issue. We really want to do whatever we can here to ensure that folks feel comfortable in providing feedback and engaging in a meaningful dialogue with one another around these topics. So Again, because we do have a bit broader participation and some new attendees today, really just want to kind of start with a, kind of just a level setting conversation or a couple level setting questions just around the impact of affordability in general. So, when thinking about drug costs today, I'd really like to hear what folks have to say about, what does affordability mean to your organization? To the extent that you believe drugs generally or specific drugs as well are unaffordable, what challenges does that specifically present to your organization? And so, when you respond, if you could, again, your name and the type of organization you recommend or you represent, if you could share that, that would be very helpful for context for us. Again, really focusing on level setting here. What does drug affordability mean to your organization? You could sort of flip that a bit, and if you believe that high drug costs create health disparities, or if you believe that lower drug costs would improve access. You could flip it and think about it the other way as well.
Hi there. I thought I'd give it a little bit
Brian,
of time.
Nice to see you. We appreciate you joining.
Yeah. I wanted to make sure that other people had an opportunity to jump in before I went ahead and spoke up.
Sure.
But I think that the intent of the legislation is to make sure that the patient at the counter is able to get their drugs at an affordable price, that they're not in the position where they have to choose between rents, food, or their prescription drugs. Again, Brian Mayo, Oregon State Pharmacy Association Executive Director. We want to make sure that the patients do get their drugs at an affordable price, but we also want to make sure that the pharmacy is not stuck with the extra cost if there is a UPL implemented. And with whatever model you decide to go forward with, I think that you do need to take a close look at the PBMs and how the reimbursement part works for the pharmacies to make sure that they're being reimbursed correctly, but also that the drug costs that the PBMs are setting is taken into account as well, because that's going to be the one that the patient's going to have to focus on. So again, taking a look at what the manufacturer does is one thing, but making sure that the patient at the counter is getting the correct price at a lower cost so that they don't have to make those decisions between rent, food, and drugs is important.
Thank you for that, Brian. Much appreciated. Does that, Brian's comments, does that prompt others' thoughts, ideas around the impact of drug affordability in general from the perspective of your organization? John, go ahead.
Hi, I'm John Cabello. I haven't had the chance to join in the past, and I appreciate this opportunity. I work Senior Government Relations Director for the Independent Pharmacy Cooperative. We're a independent pharmacy buying group. We also own a wholesale warehouse, but my focus is really going to be on the impact of this on the 35 stores we represent in Oregon. Worked with Brian, worked with a number of people, but I certainly want to echo a lot of what Align RX raised. Let me start with something I think that's actually positive here under the law is unlike other states that went ahead and adopted laws to implement and mandate an upper payment limit. Oregon's one of 6 states that has this board to actually study the issue, understand what happens in terms of the drug supply chain economics, and then make reports and recommendations back. So I think in a way, the legislature did the right thing to have the ability to do the analysis and this kind of input without a predetermined outcome of what has to be done, or worse, what's happened in other states. Just dictate that you have to set these upper limits, which now are being legally challenged. So I'm glad to have this opportunity. IPC is a group that we have stores in all 50 states, over 2,000, and we're seeing in our government relations work, we do multi-state work, so we're seeing the implications of a lot of this. I think the challenge that everybody has faced in looking at these issues is not making the direct connection of where the goal of these upper payment limits and drug affordability boards is to the patient cost, to what the costs are throughout the drug supply distribution chain, to what gets to the patient getting dispensed the drug. So I'll have to echoing a bit of what Brian said and Melanie said. Your charts are useful, but I think there are other ones out there we can get you, and you can see them from organizations like Drug Channels, that really shows the complexity of the flow through of the economics through the supply chain, from manufacturer setting a list price to what is pharmacy acquiring the drug at, to what the payer pays for the drug, and what part of that is the patient cost share. I mean, realistically, I think what most boards are struggling with, or their mission, I think, centers around, are the few drugs, the high-price drugs, specialty drugs, often biological products that are very critical life-changing for patients. These often have a large patient out-of-pocket cost, as well with many brand drugs for drug therapy continuity of care. The potentially adverse unintended consequence, and I know Melanie touched on this a bit, is if you don't set the upper payment limit at a payment floor to cover the actual acquisition costs for the drug, you risk creating 2 problems. One is drug therapy disruption, where patients won't be able to find that drug at their pharmacy of choice. The other problem Brian, I will defer to him certainly on this, representing the practice in Oregon. You create the risk of having a lot more polypharmacy, where patients then will be forced to shop around for anybody who will be able to afford to carry that drug at that price. And not knowing then in providing the therapy care where they're getting their other drugs, that it could have some unintended consequence adversely to the patient of not having their total drug therapy care taken care of. I think you need to look at what some other states have done in terms of cost base. And I know Myers and Stauffer and Luke Sindley, I know, is on this call, of what's being done with creating the NATE Act and the work you're doing federally. 3 states are setting now an upper payment limit through cost basis of paying NADAC and a fee for the true cost basis of a drug to the pharmacy, to where that's passed through and that's all the PBMs as the payers can charge the plan sponsors. Now, the other benefit to that to patients is that sets a realistic basis, not based on PBM control of pricing and profitability, but cost of the good and the service that goes into then lowering, in many cases, the patient cost on the cost share of the plan design, be it Medicaid in the states that now we're up to 30 that either do it directly through fee for service or do it through Medicaid managed care mandates, or the 3 states that are now doing it in their public employee sector programs, and those 3 states now doing it in their commercial market. I think this goal of upper payment limit and drug affordability boards is very important. You're dealing, though, a lot with the symptom, not really the root cause of the problem, and that's the lack of a transparent cost-based pass-through model for designing these drugs, payments, and what can be charged to ultimate plan sponsors. So my recommendation is really looking at a recommendation back to the legislature to do what West Virginia, Kentucky, and Tennessee have started now, of mandating that kind of cost plus payment pass-through charge only through all payment sectors, public and private. And I'll certainly stop there if anybody has any questions or wants to probe a little further.
Really appreciate that feedback, John, in the thoughtfulness and detail in that. It looks like Shelley may have a question or comment.
Yeah, John, I have a question related to that. So I hear what you're saying related to the 3 states and NADAC plus. I guess.
Partially
Can anyone hear me?
I can hear you now.
We can hear you now.
Sorry. This question would be for John or anyone else on the call. And Ralph, if you're on the call, go ahead and stop me if my questions are not in alignment with my role being here today. But I would like to ask, John, I heard what you're saying about NADAC plus in different states, but I guess my question to you or anyone else here would be, how do you bend the cost curve then on the buy side so that we're actually, I mean, in concept, I get that NADAC plus and makes a lot of sense, but how do we lower the actual buy side cost so that we are essentially, hopefully reducing or, improving on affordability in Oregon? Do you have any thoughts, or Melanie or anyone else here today, on how we can impact the buy side?
I'll give you my observations, and certainly I'll defer them to Melanie further on this. I think the best example of that is where the public sector has control ultimately as a payer and through the rebate process. If you look at what's happened with the states on using NADAC in Medicaid and what's starting now in the public sector, because they are directly the plan sponsor, they are getting true lower net costs because they are really only paying for that ingredient cost. Plus, what's occurring, because they have the ability to get enhanced rebates, they're actually benefiting a bit from what we've observed as the perversion and how drug pricing works, where their preferred drug lists tend to skew more brand because they've been able to get much greater concessions on the price, that they've actually had net savings. And I can provide a white paper just on Medicaid managed care to this board that is based on the reporting of the states and the entities of what they've saved moving to that, beyond even what they budgeted for. And oftentimes that savings is the direct cost of the drug cost. And rebates, supplemental rebates, are savings on top of that program cost. Now, granted, you don't have in most state Medicaid programs much patient share cost. So it's a bit of a different market. You do, however, have that with the public employee programs that these states have done, where they certainly can get greater enhanced rebates. And I don't know if there's enough experience yet of data to show if it's helped lower patient share costs for those public employees. I think the difficulty in your question, though, Shelley, is how do the diversity of private sector payment plans, prescription drug programs drive that? I think the benefit of a cost plus basis for plan sponsors is they'll see savings too on what they'll see as their drug savings. And unfortunately, all they've been able to use as a tool to get at that is suing PBM. So I think it may create some different pressures in up the food chain in the manufacturer's end as to how they may have to price differently. But I think what's important everybody know is we see this all the time as a buying group. Stores are searching and shopping every day for the lowest price they can get for drugs. I think it's also a very important thing for you to know that they see where prices go on drugs and reflect and react to what's happening in the marketplace. I think the other thing you have to address is eliminating any bill possibility, and I'll let Brian correct me if I'm wrong on this, or whether the PBM regulation law in place now prevents PBMs from controlling all the specialty drugs and essentially having the legal right to set the price to pay themselves higher than anybody else, or even exclude anybody else from competing. So without competition in that marketplace on where most of the money is spent, if you allow the PBMs to continue to have that control, you'll never be able to attain your goals of reducing patient cost share of that being unaffordable to get their therapy. So I'll stop at that point, Shelley. I hope that gives you some guideposts of where I think there's opportunity.
And before, Shelley, if you have a response, please jump in. If not, it looks like Melanie may have a comment, but before anyone does, John, if there are particular materials that you do want to share with the board or that you think would be insightful, please just feel free to email those to that Oregon PDAB at mslc.com email, and we'll make sure that they get where they need to go.
I will certainly do that. And I appreciate, Bobby, the opportunity to provide IPC's perspective representing on the economic side independent pharmacies in conjunction with the input you got from Brian and Melanie.
Wonderful, thank you. Shelley, did you have any additional sort of follow-up to that before I move to Melanie?
No, I want to make sure all the constituents here have time to speak, and I can reserve other questions for the.
Okay. Melanie, did you have a comment on this specific line of discussion?
I did. Thank you. And thank you, John, for articulating the cost side and heading that direction as a potential alternative. I think going down that pathway, it's important to really look at what NADAC truly means and what it's reflecting in the market. Because one of the unintended consequences with using a cost-based approach is making sure that approach does not inappropriately target or exclude a certain class of pharmacies from being able to participate under that kind of a cost-based reimbursement schematic. And so case in point, we have a perfect analysis opportunity that's occurred recently here in 2024, where, and I just finished this analysis myself yesterday with our own network data. What I did was I took a look at NADAC as an AWP discount equivalency for April and for May, and looked to see just for brand drugs, right? Because that's the biggest cost component of what we're trying to solve for here. And so in April of 24, the AWP equivalency for NADAC brand was like 20.31%. So that represents a WAC minus 4.4 something cost equivalency. So what that tells you is that pharmacies or providers of any kind, because this impacts physicians as well, so providers would have to purchase those brand products at WAC minus 4.45, whatever that number is, to break even on dispensing that drug. That's a in and out transactional. I bought it for WAC minus 4.4. I sold it for WAC minus 4.4. Zero margin on top of that for gross. And what we know is when we looked at the same analysis in May, that dropped to 20.41%. So over 4.5, WAC minus 4.5. And the event that triggered that decline in NADAC to AWP equivalency was the fact that a significant chain finally reported their pricing to Myers and Stauffer and was published. There was a significant decrease in NADAC reimbursement when this new price data set was published, and it all was attributed for the most part back to this one chain that reported their acquisition pricing. What that has now created is for independents, for the pharmacies that I represent, we were projecting margin based upon known NADAC and historical expected trends with NADAC price change, so that we could then contract with these PBMs at an AWP minus methodology, but still know that, you know, based on our buy side, on our pharmacy's buy side capabilities, that we could reasonably estimate and hit those gross margin targets. Just having this one anomaly where a single chain reports has now blown all of that, all of those projections out of the water, and we've got a significant number of community-based pharmacies that are no longer going to be able to even supply drug product at NADAC because they're just not buying at that price level. And so as long as, if you're going to go down this pathway, what you truly do have to make sure that you're accounting for is that there is still a buy-side difference based upon class of trade between a community pharmacy, a chain pharmacy, a mass merchandiser, the physician, contingency. We all are a different class of trade and have different buy points that an average like NADAC does not, on the surface, adequately adjust for. And so it's hard. I mean, I've been doing this for, you know, over 30 years now, and the buy side is the part that is the most difficult to address, because that is a contractually provider individual negotiated term and condition with the wholesaler of their choice. And then you get into problem areas like price fixing and other things if you try to legislate price points like that. And you can't start here because, like I said, going back to my opening comment, retail businesses live on margin. We have to be able to project what those gross margins are because of all of the other things that we are, by the way, contractually obligated to provide above and beyond just dispensing the drug product as part of that transaction and consideration for payment. And so you're coming in with a price sensitive approach without fully, I think, maybe making sure that you're fully addressing all of the things that go into dispensing activities and ensuring that professional fees are set at appropriate levels. And oh, by the way, all of these other things that people expect as part of their drug service are now clinical revenue. You've got to pay for immunizations. You've got to pay for spacer training. You got to pay for those, provider-centric activities that so far have been lumped into reimbursement for drug price because you're removing, especially for community-based pharmacies, you're removing the operating margin out of that drug reimbursement by going to a NADAC. So those are, and I know I hate to be the one to always point out the problems with the pieces, but I truly do believe that if we understand what the problems and challenges are, that it helps us collaborate more effectively to find the better answer, right? And when you're talking about the whole point is patient affordability, maybe the first part out of the gate is just working with the health plans to ensure that there is an effective way to cap copays or cap maximum out of pocket, or make sure that these drug categories that you're going after first aren't putting chronic patients at risk, right? Those are the more, I think, important pieces than just focusing on the, setting a maximum reimbursement amount. I think it's capping patient cost exposure. is a smaller step first step. But that's just, from what I see from looking at this 30 plus years and different sectors of healthcare delivery. So
I appreciate that insight and your experience there, Melanie. It looks like Ralph, you may have a question.
Yeah, can you hear me okay, Brian?
Yeah, we can hear you.
And Bobby, you can't hear me? Great, thank you. First, gratitude to Brian and folks for coming today, and thank you for everyone who participated. This is exactly why we are doing this exercise. Question probably to Melanie and John, and I don't want to make any assumptions, put any words in folks' mouth, but you had intimated that you might have some strategies in mind or thought. John, you had mentioned West Virginia. When I think West Virginia, I think the construct of rebates being returned to patients at passing through straight at point of sale. I wanted to follow up and ask if that's what you were speaking to, John, and philosophically / operationally, could maybe we get some thoughts from the two of you and others on the phone or on this call, rather, if that's something, as you had noted, Melanie, capping patient cost exposure being a prime concern, and we certainly share that. So is rebates being returned in their entirety to a patient at point of sale? Where you're going with that, or could you react to a thought like that, please?
Ralph, thanks for the question. I'll clarify a couple of things. So follow up on what Melanie said. I agree. What I'm looking at is where you do have a floor. The problem, I think, the challenge, set the upper payment limit as the ceiling without any relationship to drug acquisition costs. I think that's what you're hearing from Melanie and I, is where you will have disruption and lack of ability for patients to find any outlet other than the PBM's mail order or specialty drug distributor to get the drug. And I will assure you, they will do that at their benefit financially, not necessarily for the benefit of patients. I also think the one other thing I didn't point out that is a bit troubling of what is in your mandate, to divorce professional dispensing fees from the upper payment limit ignores the reality of how pharmacy drug benefits are paid and covered. What I'm really talking about is what has been done as these cost plus models that really has happened throughout Medicaid, where they design through the surveying, and I agree with Melanie, there are limitations on NADAC. The benefit of NADAC, I do think the opportunity is at least you can appeal the drug pricing through a government entity to reflect anomalies of where stores can't purchase it at that price. And I'm sure there are people from Myers and Stauffer involved in that who could talk to you about how they handle those appeals. It's certainly much more advantageous than what happens with PBMs, no matter, I think, what the track record has been on drug pricing appeals to PBMs, and nobody's really found satisfaction of that to cost basis under any state law regulating PBMs. But you can't ignore what it is for the cost of the pharmacy, which I will applaud Myers and Stauffer. I've seen a number of their cost to dispense survey models that are used by states to fully capture the cost of what a pharmacy has to go to provide that service, including carrying cost of drugs and what it costs for all the pharmacists working in that pharmacy. So I guess one recommendation I'm asking you to go back to the legislature is they have to include that as a factor in this upper payment limit. But Ralph, to your more direct question, I don't think there's anything any one state can do on rebate pass-throughs, absent the federal government mandating that. Because as you may have seen, if anybody's followed that in the Trump administration, they made a wholehearted effort to change the laws and the rules to require that down to the patient level because of the safe harbor provisions under federal antitrust law. And I'm not a lawyer, so I'm not the authoritative aspect on that, but I think the difficulty everybody's finding is how do you do that and ensure that the PBMs, as the ones processing in the drug benefit, don't use it to their advantage. It really has to be a direct pricing pass-through that they can't touch. But I think Melanie's touched on the important thing. you're trying to get at what the patient cost aspect of this, and without really ensuring that it fully covers the cost of the access point of all retail, you're going to find very difficult way of doing this without creating an unintended consequence you don't want of drug therapy disruption to the patient. So hopefully that answers some of your questions, Ralph, from my perspective.
Yes, appreciate very much. Thank you, John. And Melanie and Bobby, I want to respect. Yeah, go for it.
So I'm going to tag on an example of what John was talking about, especially in the specialty market. Look at similars. CVS themselves have actually become a quasi-manufacturer of biosimilar, right? And so if that is the only price for that particular NDC, then they get full control over what reimbursement is on a UPL, because they're the ones setting the price and they're the ones benefiting from dispensing the drug. And that's a real thing in today's market. It's not a hypothetical. So any UPL like that, you've got to take into consideration this biosimilar market that's emerging and how those specialty products are being brought to market. And when you can control the chain from, making it, being the quasi-manufacturer all the way to the provider, you own the profit on that. So I think it's critical that we understand that, and the fact that NADAC, for many reasons, they don't even establish prices for specialty. So you don't have a national benchmark marker to compare from a reasonability perspective on what prices should look like for new NDCs entering the market like this. So it's very problematic in the specialty space. And quite frankly, the reason specialty pricing has gone unchecked is because of the control that the PBM sector has had over specialty dispensing for years and years and years, unregulated. So it's a bigger set of things to consider, I think. So.
Thank you for that, Melanie. Shelley, go ahead.
So Melanie, I do have 2 follow-up questions to what you've presented, and Ralph, again, stop me if my questions are not in alignment with my role. But I'll tell you 2 questions first. So related to there not being a price, if I think I heard you right, on specialty for NADAC, if you could give us here some visibility, since you do contracting, what is done when there's not a specialty NADAC price? Because if we're talking about NADAC, I clearly want to hear where we might have gaps. And then also, I did just want to ask, I know it's all being implemented in real time, but if you do have any perspective related to the West Virginia point of sale rebates like Ralph referenced, since I know you do work on payer contracts, I am interested in if you have any feedback related to those point of discounts yet. You might not, but those are kind of my 2 questions.
Okay, so to focus in on the piece of that, and that is, how does specialty contracting kind of work at a very, very high level currently with PBMs? So,
but I guess in use cases or states where there are NADAC laws, so like if there's a NADAC requirement, how does specialty get handled if there's not a NADAC price?
Yeah, so and this applies to any drug that would not have a NADAC price, for the most part, specialty being one of those things. And usually there is default language. So it says, okay, NADAC plus whatever. And then in the event there is not an established NADAC price, it would default to either a WAC discounted price plus a dispense fee, or it would go to an AWP minus discount plus a dispense fee. And again, the challenge is with those price points, if community-based pharmacies, for example, can't purchase specialty drugs, at a typical brand discount like they do all other brands. And the pricing methodology is set to default appropriately for the more commonly available brands, then that automatically prevents a community pharmacy from being able to supply that specialty drug at the WAC minus or the AWP discount minus price point, because they just simply can't purchase it for that same price point. And there's not enough allowance for community pharmacy to be able to continue to provide those products outside of that standardized reimbursement methodology. Does that make sense? Does that answer your question, Shelley?
Oh, you're on mute, Shelley.
I just wanted to say, yeah, I just wanted to understand in the use cases of if not NADAC, then what when it's currently being used. So that answers that. And then yes, any real-time perspective on how point of sale rebates are being handled in West Virginia, I think is a question Ralph was asking if you have experience yet.
It's too soon to have enough data to analyze that yet.
John, go ahead.
Yeah. Just one other thing I wanted to add that I forgot to mention earlier, that I think you're unique in Oregon doing this, that you can look at. And maybe this gets at a better approach, a more accurate data on cost is, and certainly I know there's some people on here from Myers and Stauffer that could probably address this. Oregon, for its Medicaid fee-for-service program, does do an AAC. And as far as I know, you're still conducting those surveys of acquisition costs and invoice base within Oregon. You get a more accurate price. I certainly would want to know if you're doing what I know other states do, where they look at it distinguished by types of retail to come up with accurate acquisition costs. And there are states that do this, and I can certainly get you data on this. To get to Melanie's point, especially in the biologic areas where you got to put WAC as a replacement if there is no NADAC, to ensure access to care, and also create, as you have in your Medicaid fee-for-service program, tiered dispensing fees, but also a number of states are going to a higher fee for designated specialty drugs, where the state's controlling that. And they are determining, not the PBMs, what's designated as a specialty drug and non-discriminatory treatment, so the patients can get those drugs at the pharmacy of their choice to preserve their access and their continuity of care. So I think you might have an advantage here, not having to necessarily reinvent the wheel, and maybe finding out the benefits and detriments of how Oregon's own AAC has been operating from what Myers and Stauffer is doing for the Medicaid agency in Oregon.
Thank you for that, John. Just want to do a time check. We're right at 2 o'clock. Want to be mindful of folks' time, but also, if you do have some additional time to stay on and would like to provide additional feedback, we certainly welcome it. So I guess maybe we'll do sort of a little bit of a last call here. Go ahead, Melanie.
Sorry, one final point that I wanted to just make sure you guys were aware of is that in the setting of a NADAC price, that does not have regional adjustment. And what we all know about buy side is that the buy side true acquisition price point varies from provider to provider. So if you're trying to really look at Oregon specifically, then NADAC doesn't really reflect the true acquisition average for Oregon pharmacy providers. It reflects the national average. And so I would encourage you to maybe even consider working with Myers and Stauffer to do an Oregon NADAC if you're going down that pathway and like the cost concept. And then that way you're actually better looking at the costs related for Oregon. Cost to dispense is higher in Oregon. Minimum wage is higher in Oregon. There are all kinds of issues that drive what cost really looks like for Oregon that are not reflected across the entire country. And so I think it's going to be important to be fair to the provider communities here to really look at this from a pure Oregon perspective and not use a national. That's probably my last comment for you guys to chew on. So.
Well, much appreciated, Melanie. I think it's been great feedback and great input from everyone. Like I said, I know we're at time, but I will ask one more question just for, just to see if folks have any additional thoughts. And I think we've probably shared a lot. So if there's nothing additional, don't feel obligated. But as the board thinks about its authority to make recommendations, suggestions to the legislature, is there anything else, even beyond the concept of a UPL, that folks would want to recommend that the board consider? Any other strategies to address affordability challenges, strategies to mitigate any challenges with particular approaches or models? Just wanted to sort of give an open-ended in thinking about the board's sort of position to make recommendations. Any other thoughts that folks have? Okay. Well, if none, again, I apologize for going over our scheduled time, but do appreciate all the great feedback that folks have provided. There have been a couple suggestions about sharing additional information with the board. I know, John, you had something in particular, but if others have particular materials or additional thoughts, ideas that come to mind after this call that you'd like to share, please direct them to that email there, or as Linda had said, feel free to continue to participate in the board's public comment process, which you can access through their website. I think that's all on our end. Shelley, Ralph, anything that you guys would like to share as we close out?
Shelley, go ahead.
Oh, no, it's all I was going to say is this is exactly why all these constituent meetings were being held. This is also why the board has been working with Myers and Stauffer to, run these meetings for us. This type of feedback is exactly what we need to hear as we go through as a board to make recommendations. So again, very appreciative of the feedback today. I encourage anything in writing that we received will also be part of our kind of aggregated work product. So please feel free to, share with colleagues, and the more voices, the better, as we really work toward, trying to find solutions to help improve affordability. So just very personal thank you for this, very frank, meaningful, expertise type of guide or feedback that we've received. So it means a lot to me.
Yep, and same here, just gratitude, profound gratitude for all of you for your participation and thoughts today. So thank you so very much.
All right. Well, with that, we'll close, and hope everyone has a wonderful rest of your day.
Thank you for having us on.
Thank you.